Good evening, everyone. On behalf of Maharashtra Academy of Pediatrics as well as Cachet Pharma, a very warm welcome to all the respected seniors and colleagues. Apart from motor and behavior dysfunction, deficit in cognitive skills are among the well-documented sequelae of preterm birth. However, early identification of infants at risk of poor cognition is still a challenge, as no clear association between pathological findings based on neuroimaging scans and cognitive functions have been detected as yet. The topic for today's CME is General Movement Assessment in Neonates. The GMA has shown its merit for the evaluation of the integrity of the young nervous system. It is a reliable tool for identifying infants at risk for neuromotor deficit. So, to clear our doubt, we have with us Dr. Kashmiri Barbade. Welcome, ma'am.
Thank you, Neha.
Ma'am is a developmental pediatrician, director of Tender Steps Child Development Center, consulting developmental pediatrician, Apple Saraswati Hospital, Kolhapur, neonatal and high-risk developmental and early intervention consultant, autism intervention therapist, certified for general motor assessment, secretary, Sanmati Matimant, Vikas Kendra, Ichal Karanji, co-editor, Disha Learning Disability School, Ichal Karanji. Welcome, ma'am. Over to you, ma'am.
Thank you, Neha, ma'am. Thank you for the warm welcome. First of all, I take the opportunity to thank MahaAP platform, Dr. Hemant Gangulia sir, Dr. Amol Pawar sir. And I will start. Can we start with the topic?
Before that, I would like to welcome our MahaAP president, Dr. Hemant Gangulia sir, to give his blessings.
Thank you, Dr. Neha, madam. Good evening, and all the dignitaries on the Zoom dais. Our today's expert and speaker, guest speaker, Dr. Kashmiri Barbade, as well as our state convener, Dr. Jay Bhandarkar, our editor, and moderators of today's session, Dr. Neha Singh, the other dignitaries on the dais, as well as all the viewers on this platform for this session. Today's topic is little bit new, it seems to us. Let us see what we can learn from that, as well as on behalf of Maha Academy of Pediatrics, we would like to thank Cachet Pharma to give the valuable academic support to this session of the webinars. This is the 8th in a row, and we are extremely thankful to Cachet Pharma to help and to give the support to this academic webinar. Once again, we thank Cachet Pharma for that, and hope so we will have a good session on this little bit new topic for us. I think so. How to assess the movement in the neonate from the expert. She's a developmental pediatrician, Dr. Kashmiri Badwani, and let us learn the new things from her. And all the best wishes to the guest speaker as well as moderator, Dr. Neha Singh. Thank you, madam.
Thank you, sir. We also have with us MahaIP convener, Dr. Jay Bhandarkar, sir, with us. Over to you, sir.
Thank you, Neha. Good evening, everybody on the dais. And practically speaking, is not a new topic, though Dr. Hemant is saying is new. This is very, very important because all of you know almost our 30 to 40% of babies are delivered IGR or premature. Almost 10 to 15% of our neonates require somewhat of NICU care, and they goes to the high risk neonate. And you know that there is a lot of possibility when they suffer from the hypoglycemia, convergence, or hyperbilirubinemia, respiratory distress, hypoxia, intracranial bleed. So there's always some chance of some neuro disability later. And this, practically speaking, when you talk about the developmental assessment or maybe physiotherapy, which usually after discharge or during the follow-up, rather it is very, very important that all assessment as well as intervention can be started in the NICU only. For the listener, for the all for information. So you can involve your developmental pediatricians from start, so that you can start some physiotherapy to the neonate as well as stimulation therapy, or maybe I can say so that neuroprotective measures, and one of the things are taking care of the neonate itself, but as well as so that baby can have a lesser and lesser morbidity, mortality, as well as a better development is the future life. So I think this topic is very, very important, and I am very eager to listen to all next lecture. So thanks to Dr. Kashmiri, Madam, for this acceptable invitation from the MAIP, and thanks to Gadget Pharma for their wonderful response. I can say support for the academic sessions during this our tenure. So over to again Dr. Neha and Dr. Kashmiri. Thank you.
Thank you so much, sir. Now we will start with the CME. Ma'am, you can share your slides. Over to you.
Yeah, thank you, sir. As sir likely said, I would like to highlight some watershed lines. As before 26 weeks, I mean from 26 to 28 weeks gestation, we are actually playing with the nature, and there has to be like there we can predict some or other neurodeficit in future. So that is very but obvious. But in 6% of the preterm babies, they are likely to develop some of the difficulties in the school going age, like learning difficulties like that. And 8 to 9%, they have some abnormalities in the behavioral issues, or likely to be learning disabilities. So all these things are very well predicted. And there is one more study is recently shown that even the preterm, like we talk about the preterm, we talk about the birth asphyxia, but in between, like between the 35 to 37 weeks, 36 weekers, they are more prone for the learning disability. And they in school going ages, they literally shows many issues, behavioral issues, anxiety issues, learning disabilities. And that study has been published by MKC Nair sir. So this is all is going on. Only thing we need to catch, detect early, and intervene early. So starting with my topic. So I know the topic is like little off bit, but my idea to come up with this topic was to do a early detection of neurodevelopmental abnormalities in newborns, and so that early we can detect, and what way we can detect. There are different ways to detect it, and how we can do the intervention. I mean, we can do a various intervention, time specific interventions, and we are how we can benefit our kids with that. So as I said just now, I said the incidence, but the global incidence worldwide is around 2.9% to around 18%. That is the global incidence. And in India, there was one study it's conducted. In that they have shown that 12% incidence of neurodevelopmental disabilities. So like recently, even though if we talk about the autism also, the incidence has increased to 1 in 44. The recent study in 2021 has shown that. So what are the prevalence? This study was been conducted in France, and this data is published in 2021, where they have it is not like from birth to 5 years they have monitored. They have taken the children at 5 years and 5.5 years, and then they have categorized that, okay, somewhere 24 to 26 weaker, somewhere 27 to 31 weaker, somewhere 32 to 34 weakers, and they have seen the different neurodevelopmental disabilities in the various group of people, and almost the same mild neurodevelopmental disability in all the preterms, almost the same number. But in school going age, they have seen that the extremely preterm babies, they require the more school assistant than the late preterm babies, or babies between 32 to 34 weeks. So this is very important. So during the first year of life, delay are the most frequently reported within the motor areas, and specific attention should be paid to the infant born prematurely. So like early detection and early intervention at the grassroots level will bring down the incidence. So in this study, they have taken the various parameters like visual assessment, there are certain questionnaires, then GMF CS they have used. So like multiple things they have used to come up with the data. So like this is very important in the neonatal period, as sir said, that we need to detect early, we need to diagnose, and we need to diagnose at all level, not only in the metro cities. So before starting, let's come to the basic things like early childhood development. I always talk about this. This is one of my favorite slide. Like there is like time of formation of the base for every child. So in that formation of base, they form a foundation, and that foundation could be a strong foundation or a weak foundation depending on the environmental experiences. Like there is a model by Brenners. So that model is shown that the child himself first, then the outer core is by the caregiver, then the close family members, then the community. So we all know that. So it's all the experience-based development in childhood. So in the form of learning, education, productivity, socio-emotional functioning, and health and diseases. Also, the first 100 days are the most sensitive and the crucial in the development. So like first 1,000 days means from the day of conception till the 2 years of life. So during this phase, if there is a slight shift from the normal, then there could be a huge drift in future development of the child. Also, the neuroplasticity declines after the early childhood. So after 3 years, after 2 years to 3 years, it start declining or spooning may start. So impact of the environmental factors, parenting qualities, and brain needs nurturing care. So nature has done their job. Now it's our job to nurture the child. So evidence that the deficit in the early childhood development will not be most effective if the interventions are started after 24 to 36 hours. So why this 24 to 36 hours? We will see to it later. So why this early? Because many of the time the children comes to us with the age of 5, and I'm talking about the 24 to 36 months. So that early we need to diagnose, we need to detect prior to that in the NICU itself, as sir said. So what is the secret ingredient of that? So the capacity of the brain to change their connections behavior in response to the new formation, sensory stimulation, damage, or dysfunction. So we all know the neuroplasticity. So like neurons, the millions of neurons are they form a connections with another neuron in a second. And almost 80% of the adult brain is formed by 2 to 3 years of the age. So whenever there is a brain injury or there is a growing abnormality to the brain, the neurons are damaged, altered, or lost, causing disability. The good news is that the brain attempts to create a new path. That's the beauty of our brain, or allow the healthy brain to take over. Right. So this is very important. So we need, for example, someone with injury to one part of the brain can often recover because the neuroplasticity will allow the healthy section to assume the role of the injured section. The brain will create and reinforce the new neuronal pathway to learn the new skills, habits, and way of thinking. So different techniques, different methods to required for the strengthening. So presentation, as I just said, the neurons and the synaptic formation in newborn 1 month, then at 9 months, then see at 2 months and adult. It is almost achieved by the 2 years. So this period is very important, and this period we need to intervene the child. We need to detect and we need to intervene the child. So again, the phases of neuroplasticity. First phase is intrauterine. So whatever like can be modulated by the maternal environment. And second is pre and the postnatal in humans. So environment and to the pattern of brain activity produced by the experiences. So this is the outside the womb, and first phase is inside the womb. So functional plasticity, brain's ability to move the function from a damaged area of brain to other undamaged area. And structural plasticity, the brain's ability to actually change its physical structure as a result of learning, as I said just now. So general movement. So what are these movements? So general movements are simply the movements of our body which we observe in a child. So there is a technique how we should observe the how we should observe the movements and what all movements we should observe. So general movements. It is discovered by Pritchell in 1979. So the Pritchell and the Krista Spear, these are the two founder members of general movement assessment. And I'm lucky enough to learn from Krista Spear. And really, it was a great experience with Krista. So it has been practiced. We are practicing general movement since last 40 to 43 years, right? And it is a diagnostic tool for the functional assessment of the young nervous system. The qualitative assessment of the general movement as a specific predictor for the neurological impairment. Children born preterm have a higher rate of adverse motor, cognitive, behavior, and psychiatric outcome than their term-born peers, even in the absence of the brain injury. So the preterm children does not require like it has to be a severe some stomy course in the NICU. Even the normal born preterm, because as I said just now, the phases of neuroplasticity inside the womb, the development has not occurred. So obviously we have to give the similar environment outside the womb, right? So again, the cognitive deficit occurs in 25 to 50% of the children born preterm, especially if their birth weight is under 1500 gram. So what are these general movements? So these general movements are amongst the earliest and the most prevalent and the complex pattern of the movements. These are really complex. We need to really observe multiple times. Then only we can understand the pattern of the movements. They emerge in the fetus at 8 to 10 weeks of post-menstrual age and continue to present until the 5 months of age. So as we know that when we do a ultrasound of mother, so like around 12-13 weeks we see that the eyes are blinking, like so these are the when there is a blinking of eyes by 11 to 12 weeks of gestation, that is a sign that the dopaminergic pathways are started emerging. And then that's how the after that the general movements will start appearing in the babies. So nicely they will do all the movements inside the womb, all the movements. In US countries, what they do is they actually monitor the GM in the womb, and then as the baby born outside, also they monitor the general movements outside in the preterms or the babies. After 40 weeks, usually we don't see, and there is a 1 month gap between that. I'll come to it later, and then there will be the another moment we need to assess. The neuronal mechanism of GMs involves the central pattern generators, the CPG center in the brainstem. The CPGs are the neuronal network that are able to generate spontaneously and autonomous motor activity, but are affected and modulated by the signals from the other parts of the brain. So you can record it when the baby is sleeping also. You can record at that time also. But when you're recording at 3 months, the baby has to be awake. The separate CPGs are assumed to be responsible for that is the temporal organization, which is basically involved in the breathing and the fidgety movements. As both the patterns may be seen spontaneously during the period of overlap from 6 to 8 weeks of the postnatal age. I'll show you later. So they involve the whole body in a various sequence, like arms, legs, neck, trunk movements with the frequency, there is a speed, there is an amplitude, there is a range of movements, then there is a waxing and waning in the intensity, force, rotation, along with the axis, truncal axis, and they have the gradual beginning and the gradual end. So like no difference can be observed between the fetal and the preterm GM, as I said just now. So indicating that neither the increase of the force of the gravity after birth nor the maturation has an influence on the appearance of the general movement. So how we do it? So we do a video assessment. The recording is for 5 to 10 minutes, and duration of assessment after the recording is just 3 to 5 minutes. You just need to observe the 3 minutes video, that will be enough. With a good quality of activity, intensive training required. You need to do the basic and the advanced both. Avoid acoustic signals or stimulation during the recording. So you need not to stimulate the child. Child can be in this, child can be asleep, child can be awake, anything, but child has to be quiet and calm. Child should not cry when you are recording the video, and you should not just stimulate with anything, with the voice, with any noxious stimulus, or just by touch, or just focus. Child is focusing on your camera, then stop it, wait for 5 minutes, and then again restart the video. Then more than 3 months, child needs to be awake. So sensitivity of the GM is 94%, is very good. And the specificity less than 3 months, it is roughly between the 46 to 93%. And more than 3 months, it is 82 to 98%. And false negativity is 6%. So before coming to the movements, there are various types of movements in the general movement. So first is a breathing movement, then comes the poor repertoire, then comes the cramp synchronized movement, then there is a chaotic movement and the fidgety movements. There are 5 types of movements in this. Every movement appears at a different age. Some appears before 36 weeks, some appear after 36 weeks, some appear at 40 weeks, and some appears at 10 to 12 weeks. Okay, so these are the different moments. We need to plot it on the chart. There is a chart available. I will show it to you. Okay, so like this is how we need to record. So before going to the breathing movement, that's the first moment. So before that, we'll just see the normal movement. As I explained in the previous slide, this slide, that there is a variable sequence and gradual beginning and gradual end. So you must have seen the contemporary dance, right? There is a nice elegant movements are going on in the dance smoothly, one leg followed by the other leg, then the hips, and then the trunk, and then the upper limbs, and the neck, and all. So like this is the same pattern you can see in the movement of the baby. If you take a baby, there is a flexion of one leg, then there is a flexion of another leg, then there will be some truncal rotation, then there will be some hand movements, and this is how nicely the child does some head movements. So this is actually a normal moment, normal general moments which is there. So there is a smooth beginning and the smooth end. Everything is nice. It looks very good to see a contemporary dance. So same way it looks very good to see a normal moving child. I'm trying to simplify for you all. So what are the breathing moments? Usually breathing moments are the moments that doesn't give any breathing moments doesn't give any neurological outcome. But if it is not in a good quality and quantity, amplitude and speed, then obviously there is some issues, some neurological issues are there in child. So like they are present at term till the 6 to 8 weeks of gestation. So at term, during the first 2 months post-term, and then GMs are commonly referred as a breathing movement. So these movements are the small, moderate amplitude and moderate in speed, and also forms which creates the impression of the breathing movements. They're different movements, okay, but they are not haphazard movements. So I'm just giving you the example. So this child is full term born, 40 weeks born, and I have recorded this child after 6 days of birth, so around 41 weeks. So this time there are some components of the normal GM along with some of the breathing moments. Because of the gush of air, he is showing some jerky movements, but you can see that he flexed one leg, then he flexed another leg, then he's yawning, he's giving some truncal rotation nicely, he's turning to one side. Because the air, he was near the window. So now he has started crying. So this we are not supposed to record it. Purposefully I kept it. Purposefully I kept this because these are the mistakes we do while recording, right? So the child should be in the quiet and calm place. There should not be any gush of air or any sound, or because many a times he was showing a startle. So this is basic mistake we do when we record a GM. So poor repertoire movements. So sequence is monotonous. Then the movements of the various body parts is not in a complex way. The fluency not maintained, less variability, frequency is less, and appears from 8 to 10 weeks of gestation till the 40 weeks of till the term. So till that level, we can label the child as a PR. We denote the short form of poor repertoire as a PR. So these are less variable. I mean, you many times you see a child in the NICU and you write it as a reduced activity or child is not active enough. So this is the kind of the PR moments. So I am showing you, this is a extreme preterm 26 weeker 850 grammer. It was like a stormy NICU course for 10 weeks, and like everything he required, ventilator and surfactant and all that. On this child, we started working in the NICU only. So here you can see the fluency is not there. There are some jerky moments. Haphazardly, he is moving first the upper limb, then the lower limb. There is some PR component is there, but at the same time, you really need to have a patience to observe the videos. I just can't go fast with this. So again, see, now you can see the child eye opening is there. He's showing some finger movements, some lip movements, mouth movements. He's active and alert. This is also, there is one proforma where you need to plot all these things. I'll be coming to that. Okay, so he's giving some smile. He's trying to interact with the surroundings. He's observing the surrounding. Okay, so I will label this child that PR means the poor repertoire. This child is going to the normal. I'll put an arrow and he is going into the normal general movement. See, the neck rotation is also there. Okay, now see this child. Child is crying. So now I told one of my resident to record the video for me. So see what he did. He just kept the child. The nothing was there on the cradle, and after some time he started stimulating the child, because I told him that I need to observe the moments. I've taught him several times, but still the same mistake has been done by the resident. Here you can see the normal movements. Nicely he is moving, rotating. He is in sleep. Now both are quiet. Okay. Can I go ahead? Can I go ahead?
Yes.
Yeah. So now our third moments are the cramp synchronized. So an abnormal pattern from preterm age onwards. The moments appear rigid, lack of normal, smooth and fluent character. So like whatever you have seen, the elegance, that elegance will not be there. And all the limbs and the trunk muscles contracts and relax simultaneously. It contracts and then relax. If this abnormal pattern is observed consistently over of high predictive value for the development of the spastic cerebral palsy. Why I'm going little slow in that, because this is a very important moment. Once if you see this moment, then you really need to intervene immediately from that time, right? Because if that persists, that means there is a bad neurological outcome. That child likely to be land up in the spastic cerebral palsy. And I have seen the many cases. It's not like we have not intervened the child, but somehow because of some reason we could not follow the child, and they somehow they were living in the remote place. Some people were not aware about the what we are telling them, in spite of the several follow-ups and counseling during the NICU phase. And then we felt so bad that these kids are landing up into the spastic cerebral palsy. So I'm giving you this. So here in this, initially only he has shown the contraction and then sudden relaxation. So if you want to remember this moment, then you just see the constipated child. He will do like this, and then he will relax. Then he will relax. Like these moments, contraction and relaxation of the muscles. So he is going into the CS. He has not yet developed the frank CS. Okay. You see the posture of the hand is almost like this. You can see the restricted moments of the lower limb. Almost the plasticity, stiffness is developed in the lower limbs also. So this child is 34-weeker child, came to us with the hyperbilirubinemia, then later developed the kernicterus, and they were like, we don't want to do a follow-up now, but still we could manage somewhere, and we started with the intervention to this child. So this is a second child. This is child with the birth asphyxia. Again, the stomy course require a ventilator and ICU stay. This is on day, at this time, the child was 9 days child. Here also you can see some component of contraction and there is a relaxation. So it is not like always all the 4 limbs will simultaneously and relax simultaneously. It could be the lower limb, or it could go in all muscles simultaneously. You can observe the other moments also at the same time when you're observing for any moments. Like literally, like see the less variable moments, you can see the child is, though child is awake, child is not attentive. You have seen the first child, the tiny born baby, this 850 grammer baby, he was so active, he was looking here and there and all that activities. And see this child simply lying, less variable moments. See, here he has shown the contraction again. And then there will be the break of the pattern. So this child also going into a CS, not yet fully established the CS, but I know in between they lost the follow-up, but they again came at 8.5 months of age. That time the child has fully developed with the spastic cerebral palsy. Then the chaotic GMs. So moments of all the limbs with the large amplitude and occurs in the chaotic fluency and smoothness. And they consistently appears to be abrupt. Suddenly it comes and suddenly it will go off. So like chaotic GMs can be observed during preterm, term and early postterm age, but rare of the rarest. because I have not seen a single chaotic moment since last 6 years. I mean, I'm doing GM since last 6 years, but I have not seen, because as we are managing our kids really well, I'll say that I have not seen the chaotic moments yet. So what kind of moments are that? So like these are the jerky moments, like this. The child is like literally dancing very boldly on the cradle. Like you must have seen the Sunny Devil's dance of Yara Ho Yara. It's like that he will just simply come up with the leg and he will tap on the cradle, and same way. So this kind of moment, the abrupt sudden eruption, and then suddenly abruptly it will stop. So these are the chaotic general moments. So sorry, I could not give you any video of this, because I have not seen till date a single. I have the sample video, but I am not allowed to show it on the public forum. I need to take lots of permission from the Krista ma'am. Then fidgety moments. So these are the very important moments. These are the predictor of everything, predictor of neurodevelopmental disabilities. So like emerge at 9 to 10 weeks post-term. And these are the small amplitude, moderate speed, variable acceleration of neck, trunk, limb in all the direction continuously in the awake infant, except during the fuzzing and cry. So as I said earlier, and there is a wiggling, oscillating and sporadic arm movements, swipes, mutual manipulation of the fingers, fiddling. The fiddling means that he's playing with the clothes. Then manipulation of the finger he'll be doing, reaching and touching, leg lifting, hand, knee, hand, foot. These are all the things which comes with the fidgety. And there is a trunk rotation and axial rotation. When there is a hand, it is like a child is 12 weeks. When there is a foot, child is 14 weeks. This is simple. Like when child is doing this in hand regards, if he is showing that child is a 12 weeks child approximately. So like types, there are 4 types of fidgety. Continuous fidgety. Continuous fidgety means you will continuously see the fidgety moments in the child. Whenever the child is awake and he's playing, either he's handling, he's giving the hand regards, he's fiddling, and at the same time he's showing the, so all the fidgety moments that occurs, usually you need to observe in the joints, like the neck, shoulder, hip joint, and the ankle. This is how you have to observe in all the parts of the body. So continuous fidgety will occur in all the part of the body continuously. When you call it as an intermittent, that will be present also in all the parts of the body, but there will be a pause in between, like around 10-second pause will be there, and then again it will restart the fidgety. That we call it as an intermittent fidgety. Then there is a sporadic. Sporadic means you really need to search for the moments, like fidgety moments, whether it is in the neck, whether it is in the ankle, whether it is in the hip, whether it is in the shoulder, wrist, where exactly. So you need to look for the moments. Then that is a sporadic fidgety. And absent, that is like child is showing the variable moments, but there is no fidgety as such. So this, all the 4 types you need to observe. And if you have a continuous fidgety, that's the normal fidgety, and that's the outcome, neurodevelopmental outcome is very good with these kids. Basically with the sporadic and the absent fidgety, if there is absent fidgety, definitely there has to be some neurological deficit. Sporadic, again, you need to look after, you need to monitor the child. So just examples. So this child is showing the normal fidgety moments, and this is between the 3 to 5 months. So 3 to 5 months, this child is 4 months old. And they show the normal neurological development. The absence of fidgety, as I said, is early marker of neurological outcome, mostly the cerebral palsy. And this fidgety moments, we plot it on the actogram. We record it on the actogram. And if you see 11-week baby, you can see a sporadic fidgety because it just started emerging, appearing. So you will see the sporadic in between. And then if you take a child of 12 weeks, then there will be an intermittent fidgety. And more than 10 weeks, there will be a continuous fidgety. So you will see a continued graph on the actogram. So yeah. So on this, in this child, again, I'll explain you. See the finger movements, see the fidgety. There is a like puppet-like movement will be there. Like if you put puppet on the cradle and see his child is bouncing. Okay, so this bouncing babies are continuous. See, now it is shown in shoulder. Now it is in the hip. See, again in the shoulder, he was showing in the neck, in the hip, and in the ankle. Again in the hip. It's continuously going on. Okay. Then see this child. There is some in the neck. These ankle movements are the moments that wasn't a fidgety. So I will label this child as an absent fidgety or a sporadic fidgety. So when I label a continuous fidgety, I'll write F plus 2 plus, right? If I want to write intermittent fidgety, 1 plus, and sporadic plus oblique minus, and absent fidgety AF, I will write that. I'll come to that. So now this child is 2.5 month child. Good weight. See how nicely he's showing the movements. He's trying to show the foot also. Hand is already there right now. He's not doing that when I was shooting. And he has started developing the fidgety. It is an intermittent fidgety because there is a pause between. So this is a normal, this is absent or sporadic fidgety, and this is the intermittent fidgety. Okay. So coming to the interpretation. So from 10 weeks to 40 weeks, like you can label it as a fetal and preterm general movements as a poor repertoire, that is PR, or CS, or CH, that is a chaotic movements. So CS, cramp synchronized movement, will appear after 34 weeks of gestation. It won't appear before that, and it will go off after 40, maximum 40, as I have said, just like early. So like that will disappear by 40 to 42 weeks. So whenever there is a preterm below the 20, between the 26 to 34 weeks, only we need to observe the PR moments, that is a poor repertoire moments. Okay. And fidgety will develop later. Fidgety will develop at around 12 weeks. It will start appearing in some babies. You can see some fidgety in 10 weeks also, but ideally from 12 weeks to the 30 weeks, that is 5 months. Okay. So how we are supposed to plot it? So this is a chart where I suggest that every newborn every preterm should have this chart in his file. Okay. So like, let's see, like 32 weeker, I saw preterm. Then again, I will reassess the child ideally every week, but it is not possible in Indian scenario. So I basically follow 15 days follow. So like then I again observed it. It was showing the PR only. Then at 36 week, it was showing PR. Then obviously I've started with the intervention and all that. Then I could see that PR is going into a normal by the age of 39 to 40 weeks of gestation. And then you have to label the fidgety also, where it appears, whether it is normal or abnormal. So if you have seen, so like here, the fidgety, as I said, a fidgety absent, fidgety 1 plus is a sporadic, intermittent fidgety. Then CS is a cramp synchronized. CH is a chaotic. PR is poor repertoire. N is normal. And hypokinesis. So like that is in the breathing moments usually, but we need to go in the details of that. So I don't want to go in H right now. So what is the trajectory, developmental trajectory of general movement in NICU graduates? So when you see a preterm child and you saw a normal or poor repertoire, so like after that, again at 6 weeks, you assess the child, you see the normal breathing moments or a poor repertoire, PR also. But if you see a good fidgety, normal fidgety, the neurological outcome is normal. If you see PR or CS, cram synchronized, at 6 weeks also you see the same. At 9 to 16 weeks, you could not get the fidgety moments, then it is likely to be the bilateral spastic cerebral palsy. And believe me, the very studies has been done on all the aspects. There are thousands of articles there with the GM Trust, so you can go through it. So these are all the studied, proven data. So this is what the trajectory of graduates if we don't intervene early. Then the PR with the CS at 6 weeks, again there is absent fidgety moments or asymmetric segmental moments at the individual digital moments. Then there is a unilateral spastic cerebral palsy. If PR, again in 6 weeks PR, then there is absent fidgety or absence of foot, as I said. Then the circular arm movement is also absent. Fingers spreading is also absent. Then likely to be the dyskinetic cerebral palsy. Then poor repertoire. Again, the PR at weeks and can have a normal or abnormal or absent fidgety moments. Then the various genetic disorder we may need to think of, or any inborn error metabolism also we need to think of. Then the poor repertoire, again the 6-phase poor repertoire, abnormal fidgety moments or the normal fidgety moments with a monotonous character. So like it is very monotonous, child is not interactive, child is not observing the surrounding, not interested in the surrounding, the monotonous character is there. So it is likely the child may land up into the autism spectrum disorder. So this is a very good predictor of that the child may land up into autism spectrum disorder, and see how early we can predict it. We are predicting at 5 months. So that's really good that we at least we can tell the parents to intervene from that moment. Then again the PR at preterm age, then the PR at 6 weeks, normal or sporadic fidgety moments with the monotonous, jerky or stiff characters, or lack of various finger postures, that is a cognitive dysfunction. So this is all we can diagnose just by observing the child, just by noting the various moments of the child. So this is very important. So in other way, it has been given very nicely. If you see a cram synchronized child and absent fidgety, the outcome is cerebral palsy. If you see the poor repertoire and you see again here you can see all three. Poor repertoire can go into the normal, abnormal or absent fidgety moments. But again, the absent is cerebral palsy. Abnormal could be cerebral palsy, mild neurodeficit, or it could be normal. But if it is a normal, it has to be normal, and there could be some mild neuronal deficit we can see. So I was talking about this chart. This is a GM optimality score. So this normal score is 42. So here you can see, here we can nicely observe the upper limb extremity, upper extremities, lower extremities, neck and trunk, and the sequence, the various amplitude we need to observe, speed we need to observe, the range of motion we need to observe. So every cram synchronized or it is a monotonous or tremendous movements, everything we are observing and we are marking here, and on that basis we come with the score. And that score we need to maintain, we need to follow the score, and accordingly we can assess whether the child is likely to be land up in the neurodeficit or not. Then again at 3 to 5 months, that was for the preemie. This is for the preterm and term age, and this is for 3 to 5 months. So this is also very good. Here, if you can see, just give me a moment. Yeah. So here you can see, you have to observe the movement patterns, like whether the fidgety movement is present or not. So here you can see the fidgety movement. If it is present, then directly score will go to 12. And this motor optimality score is 28 to 5. So if it is less than 20, it is likely to be a neurodeficit. If it is more than 20, the outcome is very good. And if it is 5, 6, or if it is less than 12, then outcome is very bad. So this we need to observe. See, nicely they have observed everything, like movements are there, oscillation, whether the child is kicking, excitation burst is there or not, no, mouth movement, head rotation, hand mouth contact, fiddling is there, foot, hand, arcing, roll to side, visual scanning, whether hand regards, everything they have given. You have to observe whether the head is midline or not. Then again, you can see in there is another, you can correlate here, that in developmental supportive care, we talk about the IPAT score. So in that also, you need to see the head is in the midline, and the degrees are also given in that nicely. The same way, the head should be in the midline, whether it is a symmetric or symmetric. Everything is nicely explained in the this form. Only thing you have to put it like normal, absent, and on the basis of that, we come with the score of the motor optimality score. So what are the brain parts are involved when we see a GM? So like brainstem, CPGs, occipitoparietal area, and fidgety movements, basically corticospinal fibers, basal ganglia, and cerebellum output. So these are all the parts are involved in the GM movements. So now just see what all the tests are available, like when we talk about the assessment in the newborn. So this GM I just talked about, it gives the neuromotor behavior and cognitive outcome. It is a video assisted, as I said, 3 minutes, sensitivity and specificity is very good. It is a bit costly and training is required. And then Hamilton angle, there is a TIMS, there is high, like Hammersmith neonatal assessment, neurological assessment, and Hammersmith infant neurological assessment. So all these things, basically they monitor the motor behavior and cranial nerves in movements. And the STIMS and Hamilton, basically only the neuromotor component. So this is, I tried to simplify for you all. So let's see the success stories. We have seen the lots of problems, many babies with many things, and how we are supposed to diagnose it and all. So let's see this child. This child is a 800 grammer, and now the corrected age of the child is 11 months, 3.5 months of STOMI course in the NICU. See the cognition. See her excitement, she's reaching object, lateral cruising. Foot placing. She's trying to vocalize also, she said. Okay. Then see this child, some bitter memories also. When I have observed this child first time, he was in NICU. He's 32 weeker, required again a STOMI course in the NICU. And then after that, they couldn't come to me. I don't know why, but at 8 to 9 months when they visited, see the posture of the child. There's dystonic movements, head holding is also not proper, toe placing. See, the 9-10 months child should get prone, should be more active. But within 2 months of intervention, that child has started interacting nicely. We could, some swipe moments have also reduced, dystonic moments are reduced. So take home, it is a general moment. These are the less time consuming, easy to acquire and cost effective with the good sensitivity and specificity. Cerebral palsy require the early diagnosis as a motor and cognitive gain are greater with the diagnostic specific early intervention. A behavioral biomarker of later motor and cognitive dysfunction in the NICU graduates and premature babies. Then the predictive value of the development of neurological deficit, in particular of CP, at very early stage. The normal GMs along with the normal motor repertoire during the first month after the term are the marker for the normal cognitive development. Thank you.
Thank you, ma'am. It was a very wonderful presentation. We got so many new things to know today. I would like to call Dr. Jayashree Shivalkar, ma'am. Jayashree, ma'am. And Dr. Nilima Bhandarkar, ma'am.
Hello.
Yes, ma'am.
Yeah, it was wonderful presentation. It was a very new angle to look at these abnormal movements and get something out of it. Very systematically presented. Nice one. Yeah.
Thank you, ma'am.
Yeah.
Jayashree, ma'am, are you there? I think so. She is not there. Jay, sir, have you any queries?
I think it was a very excellent presentation. I have heard this. I was a moderator for this epigenetics, and it was new topic to me at that. Initially, I was joined that session as a delegate, and later on was moderated also. And going through all this session and other things or literature, I think these first 1,000 days are important. But before I can say that 1,000 days, taking up, I always say what is a factory. The mother is the factory of the newborn, right? And you should take care of mother properly. So we are coming with this newborn week. Where I said the flyer should be made to take an antenatal care, and that should include even age of mother, when she marry, how she should be taken ANC care, and about the diet, nutrition, and other things. And we talk about the genetics, but the environment factors are also very, very important for the child to develop properly. And rightly said, all this intervention, right? Initial assessment is important. Rather, when we concentrate only on the NICU graduate, rather I say you should consider each and every neonate born, a newborn born in this country or in the world, because even slight deviation from the normal development, you should start intervening. Simple. Not necessarily you should label any, I think, cerebral palsy or other a specific diagnosis of the child. Rather, you should start intervening from initial phase like a stimulation therapy, even physiotherapy, and other things already said. So I think it's also so wonderfully presented. And I have heard this treatment of cerebral palsy long back. Somebody presented with all Botox and other thing, many treatment. But I am very much confident. Suppose start very early, immediately, assessment as well as the intervention, smaller even, and take help of development pediatrician from early stage of the life only. So that will give the great help to the newborn and other this children to kid develop, because we know 40% of the kids all over globe at the risk of not reaching to their potential, what I say, productive potential. So this can be very, I think, if world has to develop properly, right? Taking care of mother and initial our I can say our nation's the future citizens, right? Our world's future citizens, they have to be reach to their proper potential. So that intervention actually in long term have a long lasting effect on the humankind. So thanks to Dr. Neha for moderating session, and thanks to Dr. Kashmiri Badwade madam for wonderfully presented. And yes, it is like almost like a super specialty, very difficult to understand, but very easy to refer to the development meditation, because usually we concentrate on social smile by 2-3 months, and around 4 or 5 months neck holding, then crawling by 9 months, which is mentioned in the Nelson, and some other gross factors. So we usually say these things are normal, the child is normal, which is not so, because a lot of other things are also there, so they can do it very assess better when start intervening. So thanks to
And
all
by
this.
that time, the social smile and all these, when they come, we can, through this charting, we can get early detection.
Right.
We also
So
have Sameer sir with us. If he wants to ask something, Sameer sir. Sameer sir, do you want to ask something?
समीर सर फक्त जॉईन झालेत का?
I'm here. I was just trying to
Hi,
get
sir.
it off. Hi. There are so wonderful examples I never thought of actually, but they are like really very nice ones was mentioned. Intermittently, I have to get out of this station because I was in the OPD. But the example what I have seen was very nice. Thanks, Neha, for this wonderful opportunity you've given at this moment, and we are able to see all this work done by the Barbade madam. So thank you so much, Kashmiri madam.
Yes, sir.
So that is very good, nice work you have done, and you have shown so much examples. Those who have attended this program, they will definitely feel something new today. Those who have not attended, we might need to send these videos as we usually do on the YouTube. I don't know whether this today's lecture will be seen on the YouTube.
Yes, sir, definitely we will.
Yeah. Okay.
Gangolia sir, do you want to add something?
he's in Diwali party, pre-Diwali party.
He was there. Okay, sir. Yes, sir, you can.
Okay, so thank you again, Neha, Dr. Kashmiri, and all audience, and as well as DIP, Dr. Akshita, for wonderful support, and Catchet Pharma for the academic grant given to the AOP. So we'll meet again, and here I just invite. I don't have a number of Dr. Kashmiri with me. Please share with me so that I can talk for tomorrow, so that
Yes,
different
sir.
ideas.
Yes,
तुम्हाला काहीतरी काम देणार आहे मी महत्वाचं. Actually, it was already in the plan, and as well as Shivalkar madam, I talked with Amol also. So this is something need to be about the development and adoption. So we'll come back to me. So thank you. Good night, everybody. And please do
Thank
join
you,
Good
thank
night.
you,
all
thank
the
you,
program.
Dr. Jay, Dr.
Sir,
Neha,
sir,
Dr. Sameer. Wonderful episode. Great,
That
Dr. Kashmiri.
Thank you.
Great,
Thank you,
Jay.
sir.
Thank you very much. And we would like to thank Catchet Pharma for sponsoring all the 8 sessions of this wonderful sessions. And we look forward also for further any academic support to our academic activities. And thank you, Dr. Neha, Dr. Jay, Dr. Sameer, Dr. Kashmiri Balbadi. Thank you very much.
Thank you, sir. Thank you.
Okay, good night. Happy
Good
Diwali
night.
to all of you.
Happy Diwali to all of you, sir.
Happy Diwali to everybody now.
Thank you.
Do we have any presentation during Diwali? I don't